Well, Dobry Den. Thank you very much for this opportunity. My name is Ethan Russo. My email is on this first slide that I hope you can see. And I would be very happy to hear from you with your questions. We have a wide-ranging topic today, and let's begin. So we're discussing cannabis sativa, that means cultivated cannabis. This is a very versatile plant that provides food from the seed, fuel from the oil from the seed, fiber from the stalks, and of course, pharmaceutical products, usually from the unfertilized female flowering tops. Cannabis is an interesting species. It's an annual that's dioecious, meaning that it has sexes on different plants. And it's in the Cannabaceae family, which is related to the hops plant. Knowledge of what's now called the endocannabinoid system came from study of the plant. The plant makes glandular trichomes, which we see here, these spheres on top of these little stalks that contain the cannabinoids and terpenoids. Best known cannabinoid being THC, delta-9 tetrahydrocannabinol. So, THC resembles natural endogenous cannabinoids, particularly anandamide. They both bind to the CB1 receptor as weak partial agonists. Endocannabinoid tone is a function of the levels of the endogenous cannabinoids, the status of the receptors, and their enzymes. Next slide, slide 4, please. These are ancient names for cannabis in various languages. I would draw your attention to the fourth one from the top, the Chinese. You will be able to recognize stalks of hemp drying in a shed. And then we have the other languages. Next, slide 5, please. There is an interesting distribution of cannabinoids in the plant. There are none in the wash seeds. Until recently, it was felt that there were none in the roots, but recently some have been found. Very, very little in the stem. Although some people are using leaves, they have a tiny percentage compared to what's in the unfertilized female flowering tops, as you see in the slide. Next, slide 6, please. The cannabinoids and terpenoids are produced in structures called trichomes. These are in the sphere on top of stalk. These are actually toxic to the plant and are held away from it. This is in distinction to what we see on the right, where they're what are called sessile trichomes that are much, much smaller in size. So the most concentrated source of the cannabinoids and terpenoids is on the left in the flowering tops, what are called capitate glandular trichomes, which have a much higher volume as well. Next, slide 7, please. But the female flowering tops are not the only source of possible interesting biochemicals and pharmaceutical agents from cannabis. We mentioned the leaves. They are actually quite rich in another substance called cannaprine, which is a very powerful anti-inflammatory. And there are details of these different parts of the plants in the article that you see in the middle, which was recently published. As mentioned before, the seeds do not have cannabinoids, but they do have a very interesting nutritional profile with high protein that is digestible and essential fatty acids, which are very health promoting. The roots, although until recently have been felt to have no cannabinoids, do have interesting triterpenoids and even alkaloids. The latter are not present in other parts of the plant. The seed sprouts can produce a substance called canflavin, which again is a very powerful anti-inflammatory. Next, slide 8. This is the biosynthetic pathways in the plant for production of not only cannabinoids, but terpenoids. In the middle on the left, you'll see the two main precursors, olivotolic acid and geranyl pyrophosphate. These in turn produce cannabigerolic acid, which in turn will produce tetrahydrocannabinolic acid, cannabidiolic acid, and others. So in the plant, there are these carboxylic acid precursors, which more commonly are decarboxylated through heat, either by smoking, vaporization, or baking to make THC and CBD. However, these cannabinoid acids have important properties of their own. Additionally, geranyl pyrophosphate is a precursor to both the production of monoterpenoids and sesquiterpenoids, aromatic components of the plant that also provide medical attributes. As we see in this slide, geranyl pyrophosphate leads to limonene and then production of other monoterpenoids. And in the next slide, geranyl pyrophosphate also provides sesquiterpenoids such as caryophyllene. Next, slide 11. Just a bit about tetrahydrocannabinol, or THC. This was first positively identified by Professor Meshulam in 1964. It is a weak partial agonist at the CB1 receptor, analogous to anandamide, which acts in a similar fashion. Of course, this has strong pain-killing properties and also works against itch. It is a bronchodilator. In the past, there were actually cannabis cigarettes used for asthma. Some time ago, it was shown that THC is a neuroprotective antioxidant and may help prevent damage from strokes or oxygen loss. THC has 20 times the anti-inflammatory power of aspirin and twice that of hydrocortisone. Of course, it's a muscle relaxant. One preparation, nabiximols or Sativex, is approved for spasticity and multiple sclerosis in 29 countries. It also is well known as an antiemetic, especially in preventing vomiting from cancer chemotherapy. It does all these things without being a COX-1 or COX-2 inhibitor. It also has been shown that THC interferes with the production of beta amyloid, which is of interest in helping to prevent Alzheimer's disease. Next, slide 12. Cannabidiol was isolated in 1940, but only positively identified in 1963. For a long time, it's been known that when CBD is present, it will block some of the side effects of THC. But until recently, we did not know why. It is working as a negative allosteric modulator of the CB1 receptor. That means that it changes the conformation of the receptor and makes it harder for THC to bind there. It also is a neuroprotective antioxidant. For instance, it can prevent damage from excessive glutamate excitotoxicity after head injury. And it's also a stronger antioxidant than vitamin C or vitamin E. It also is a TRPV1 agonist like capsaicin and can be useful in that fashion in treating pain. Additionally, it has been shown to be a serotonin 1A receptor agonist, which it helps explain its role as an anti-anxiety drug, reduction of damage after strokes, and is the mechanism of action for the effects of cannabidiol on nausea. as well as other explanations. Another of its effects in chronic use, it inhibits the uptake of anandamide, the endogenous cannabinoid, and weakly inhibits its hydrolysis by the fatty acid aminohydrolase enzyme. Next, please. There are a lot of misconceptions about cannabidiol, so much so that I recently wrote an article about that addresses this. Some preparations will tout that they have a small amount of CBD, and although it is a remarkable treatment, it is the case that it's not a very potent one. Generally, one needs a large amount of it, so a tiny amount is not enough. Also, you will hear that cannabidiol is sedating. This is not actually the case. At low and moderate doses, it's quite alerting. This has been shown through electroencephalography. It may be sedating in combination with other drugs at extremely high doses, like are being used in treatment of Dravet syndrome and Lennox-Gastaut syndrome. Additionally, many preparations that contain cannabidiol from the plant also will be very high in myrcene, which is a sedating terpenoid, and that helps explain this misconception. Some people think that CBD is legal in the USA, but it actually is not. Fortunately, most countries have more scientifically accurate assessment of CBD and recognize that it is not a drug of abuse and it is not a scheduled drug in most countries. Also, there's recently been controversy about whether CBD taken orally turns into THC in the body. It does not. And if you need more about that, I'd be happy to send the paper to you. Next, slide 14. This is again a flow diagram of how CBD is made from the plant, again from glandular trichomes. And you see the metabolic pathway again, as from this article. Some companies are making pure crystalline CBD. And as you see here, in the body, it is converted to 7-hydroxycannabidiol by the liver, occasionally 6-hydroxycannabidiol, but it is not converted in the stomach to THC. Next, slide 15. Until recently, almost all of the cannabis that was available on the black market was very rich in THC. This is a byproduct of prohibition. People would want the highest concentration of THC so it could be stored in the smallest space. In the last few years, there's been more interest in developing chemovars, chemical varieties of cannabis that are richer in CBD to make use of its beneficial properties. So there's been a lot of debate about whether one chemovar of cannabis produces different effects than another. Since almost everything until recently has been high THC, if there are those differences, they must be related to something else. And the most likely candidate for something else, it has to do with the terpenoid content. So I'd like to spend a little time on that. Next slide, 16. What are terpenoids? So as mentioned before, these are aromatic molecules in plants that come from the flower's fruit, leaf, or sap. They're formed of 5 carbon units called isoprene units. Terpenes only have carbon and hydrogen, while terpenoids also contain oxygen and rarely other molecules. Monoterpenoids are the most volatile and aromatic. They have 10 carbons, examples being limonene, pinene, and myrcene. Sesquiterpenoids are more stable. The most common in cannabis, containing 15 carbons, is caryophyllene. There's only one diterpenoid, phytol, in cannabis, and the triterpenoids with 30 carbons are only found in the roots. Next slide, 17. Terpenoids are actually the largest group of plant chemicals. There have been over 20,000 that have been described. And these are not produced in isolation. They're always complex mixtures that the plant makes, and they fulfill ecological roles for the plant, either attracting pollinating bugs or repelling bugs or having antibiotic properties. The plant doesn't make this so that they smell nice for people, because it requires a lot of metabolic energy for the plants to make these. As mentioned before, they're in specialized sequestered structures. In cannabis, this is the glandular trichomes. Most of these are highly lipophilic molecules that have no problem crossing the blood-brain barrier. The lower molecular weight monoterpenoids are volatile and most responsible for the smell, but also the easiest to lose. Next slide, 18. What the terpenoid content is of a given plant of cannabis is under genetic control. Some enzymes produce multiple products, and these complex mixtures may make it easier for the plant to get rid of predators. The constituents may be synergistic in their activity, depending on the blend of the mono and sesquiterpenoids determines how viscous or sticky the mixture will be. We know that in the plant that higher light pressure will increase the amount, but if the soil is too fertile, the amount of terpenoids actually decreases. This is one reason that many of our herbs are grown in poor soil, such as lavender in Provence in France. How these work varies from one to another, but often these do work on membranes or specific receptors and enzymes. Next, slide 19. We know that various of the terpenoids in cannabis have pain-killing properties or anti-inflammatory properties. Many affect our psyche. They can be antidepressants, anti-anxiety agents, and many of these modulate the effects of THC, acting in synergy with them. Here we have a chart from an older paper, and you'll see some familiar plants. So limonene is common to lemons and other citrus as well as cannabis, pinene from pine needles, myrcene from hops, linalool from lavender, etc. And caryophyllene from peppercorns, among many others. Slide 20 next. Now, there is a lot of writing on this slide. I just wanted to give you an idea of how much we know about these compounds, and we're just going to concentrate on a few items that I will discuss. And again, I've written a great deal about this and can send you the papers if you wish. So pinene is the most common terpenoid in nature. It is anti-inflammatory via prostaglandin E1. It's readily bioavailable through inhalation and has a bronchodilating effect, as does THC. It is a wide spectrum antibiotic, but its most important role is that it is an acetylcholinesterase inhibitor. So what it does is prevent the breakdown of acetylcholine in the brain, and this helps to eliminate the short-term memory impairment that THC produces. So someone who needs to work or study and treat their medical conditions such as pain should look for a type of cannabis that has pinene, so they will be able to concentrate and maintain their train of thought. It also has recently been shown that this produces, helps prevent oxidative damage in the brain produced by hydrogen peroxide. Next, slide 21. I've mentioned myrcene previously. It is an anti-inflammatory and is quite sedating, as I mentioned. It has muscle relaxant properties and will potentiate barbiturate sleep time. In English, there's a term for what it does in cannabis, and this is couch lock. What this means is, in combination with THC, myrcene is so sedating that the person can no longer move off of the couch. So this is good, I suppose, if someone needs to sleep, but it's not helpful when someone needs to work or study and treat their condition. Unfortunately, myrcene is by far the most abundant terpenoid in most commercial chemovars of cannabis, so it's important to selectively breed for other things. The analgesia that myrcene produces is actually blocked by naloxone, the opioid inhibitor antagonist, so it does have a very narcotic-like effect. Next, slide 22. Probably more therapeutic is limonene. This is a little less common than it should be in available chemovars of cannabis. This is a potent antidepressant and immune stimulator. It's shown in humans. In Japan, they put this in the air on hospitalized depressed patients and were able to cut their Hamilton depression scales in half and get them off of antidepressant medicines. It also is a strong antifungal. It's rapidly taken up after inhalation. It has shown some activity against various types of cancer. The doses required seem to be very high, but in combination with cannabinoids that also have anti-cancer properties, it may be that there will be synergy demonstrated. It also is an agonist at the A2A adenosine receptor and could synergize activity with THC, which directly activates it, and with cannabidiol, that's an uptake inhibitor at that receptor. It also has been shown that limonene increased mitochondrial biogenesis and could help turn white fat into brown fat. So this could be useful in treatment of obesity. Next, slide 23. Linalool is another terpenoid, monoterpenoid from cannabis. This is well known from lavender, the most common source, and is well known to be an anti-anxiety and mildly sedating agent. It also has very powerful local anesthetic effects, which could be useful in skin preparations. And it has anticonvulsant properties and has occasionally been shown in cannabis to be helpful in treating epilepsy along with cannabidiol in particular. Next, slide 24. Terpinolene is common in some chemovars of cannabis and absent in others. It is found in parsnips and produces the aroma of that vegetable. This is recently shown to prevent LDL oxidation, so this could be interesting in helping prevent coronary artery disease. Interestingly, we have some contrary information. We know that when mice are exposed to this, that it seems to sedate them. They move around less. However, when this is present in cannabis that humans inhale, it seems to be more alerting. And again, there is a cholinesterase inhibition with this substance. Next, slide 25. Beta-caryophyllene is a sesquiterpenoid and a very unusual molecule in that it also is a cannabinoid because it is a selective full agonist at the CB2 receptor. So this receptor modulates inflammation, but it isn't psychoactive. In other words, this agent by itself will not produce a high like THC. And although it's a very powerful anti-inflammatory, comparable to phenylbutazone, It does not harm the stomach. It actually protects it from ulcers. The CB2 agents, among other things, may inhibit hepatic fibrosis and fibrosis elsewhere. Additionally, similar drugs have been shown to decrease cocaine administration, and it may be that caryophyllene will be very useful in treating addiction to other substances. Next slide, 26. This is a very complex slide from an excellent paper from 2011 that shows all the different effects of the CB2 receptor. So anything you see here in terms of protecting the liver, the heart, the brain, may also be applicable to caryophyllene. I would emphasize that THC also affects the CB2 receptor, but because it affects CB1 as well, it can be rate limiting in terms of the side effects that are produced. Next, slide 27. One of the great things about cannabis is that it's not one active ingredient. So the ability of different components of cannabis to produce a greater effect is one of synergy or boosting of effect. When this is applied to psychopharmacology, we can look at different combinations. So for depression, it's been shown that THC, CBD, and CBG, cannabigerol, all have benefits. And certainly limonene is well proven in this regard, but these combinations may be more effective. This is something that remains to be proven. There are planned randomized controlled trials to look at the effects on mood in a measurable capacity, combining these different components. For anxiety, cannabidiol has benefits, and limonene and linalool also may have, and again, the combination may be more interesting. For sedation, combining THC and myrcene is very effective. There have been various studies of agitation, particularly in Alzheimer's disease. Both THC and CBD may be helpful, and there have been observations of this. But additionally, limonene might help with mood, pinene with the short-term memory. Keep in mind that some symptomatic treatments for Alzheimer's have anticholinesterase inhibition as their mechanism of action. And linalool has been used in lavender to treat agitation in Alzheimer's already. For sleep, THC plus caryophyllene, linalool, and myrcene may all be valuable. And for addiction, combining CBD plus caryophyllene, maybe a touch of THC as well. Next, slide 28. Very briefly, canflavin is a flavone that's unique to cannabis. It's found in the aerial parts. It's very difficult to isolate from an isomer, canflavin B, but it's shown that it inhibits prostaglandin E2 30 times more powerfully than aspirin. It also affects something called MPGES1. Bottom line is this has a very interesting anti-inflammatory profile without being a COX-1 or COX-2 inhibitor. So this is a very interesting substance, can be produced in the sprouts with no production of cannabinoids, and thus could be used as a supplement without being a controlled product. Next, slide 29. I just want to say a little bit about land races. Land races are chemovars of cannabis that have been grown outdoors in a specific geographic area. And so because of this, they're ecologically adapted to the local conditions. They may know how to fight off diseases there or prevent being eaten by bugs in the local area. Unfortunately, around the world, land races have disappeared. People in Jamaica, Colombia, Morocco, Afghanistan, and Thailand have actually gotten seeds from the Netherlands or from California and are growing those instead of the traditional varieties of cannabis. In the process, some important traits have been lost. So an important endeavor will be to go out into the world, find some of the old land races and use these as breeding stock to improve cannabis vigor and therapeutic potential. Next, slide 30. There is a great deal of controversy about nomenclature in cannabis. You'll hear about sativa, again meaning cultivated, versus indica, meaning India. But the debate about this has gone on for about 250 years. Linnaeus on the left first described cannabis sativa, but a generation later, Lamarck in France described something he called cannabis indica. But you'll see in Lamarck's plant that it is narrow-leafed like the other one. What people commonly call indica today are plants from Afghanistan that look nothing like what Lamarck described. The plants from Afghanistan are very short, a meter or less, very bushy with wide leaflets. Bottom line is these assignations, sativa and indica, are meaningless. What is more important is the biochemical content of the plant. Slide 31 next. So how do we describe cannabis? Well, it is helpful to know what the plant looks like, how it's been used. The basic class is based on the primary cannabinoid. Type 1 for THC rich, type 2 for equal amounts of CBD and THC, type 3 for CBD predominant. We are interested in the leaflet shape, but again, that doesn't tell you what the chemical content is. We need to know the specific cannabinoid content and the specific terpenoid content. Also, it may be helpful to know what it smells like, what it tastes like, what is vaporized, and most important, what patients say about how it helps them or doesn't help them. Next, slide 32. On the right is a scheme that I think is very helpful to physicians or consumers in describing what a plant does. This is called phytofacts. Again, this has been published. And you see from the top that it says the percentage of cannabinoids, 23.3%, the terpenoids, 2.3%, the moisture content. You see a ring showing the most common cannabinoids, picture of the buds. In the third panel, you have a description of the aroma and flavor, likening it to, in this instance, lemons and black pepper, and then what people report about how it affects them, how much comfort, how much pain reduction, and then very important is the terpenoid profile at the bottom. And you see that this plant is very rich in caryophyllene, so it should be good for pain because it's high THC and high caryophyllene, hitting both CB1 and CB2 receptors. It's also very rich in limonene, so it should have antidepressant effect, and it's very low in myrcene, so it should not be sedating. And we can tell all that from this one page. I'd like to see more of this out in the marketplace. Next, slide 33. Just a comparison, nabiximols or Sativex is the pharmaceutical product made from cannabis extracts that's approved in 29 countries in the world for spasticity and multiple sclerosis. You see that it contains THC and CBD, a smattering of terpenoids, as compared to Moroccan soap bar resin or hashish, which contains a bunch of material that shouldn't be there. Often is cut with hair or soap or even camel dung, and certainly that isn't medicine. Next slide. People often question how you can make a pharmaceutical product from a plant. It requires a great level of quality control and selective breeding to make tight tolerances that are necessary. But this is a biochemical fingerprint of nabiximols, that approved product, 25 batches over 9 years. Now, what's most interesting about this is, first, the full spectrum of different cannabinoids, but that the quality control is so good that these overlap traces only look like single peaks. So this is a very highly standardized product that's been acceptable to regulators around the world. Next, slide 35. A little bit about dosing. This is something that's often lost. People really don't know what to recommend. But dosing need and tolerance depends on the patient's prior experience with cannabinoids and their underlying cannabinoid tone, which is something that we cannot easily measure right now. We don't have a test for it. The best advice is to start at a very low dose and increase only slowly. In general, 2.5 milligrams of THC is a threshold dose. Some people will feel it quite a bit. Some won't at all. 5 milligrams is usually efficacious and tolerable. 10 milligrams of THC produces a strong effect, except in people who are already tolerant to its psychoactivity, and it may be too much already for many people. Doses greater than 20 to 30 milligrams a day before tolerance risk psychoactive and other adverse events, anxiety, paranoia, etc. And particularly with the addition of CBD, it's often not necessary to go to doses of this type, which may seem low in a recreational setting, but medically it is not necessary for a person to be high or intoxicated to have the benefits of the cannabis. Having CBD and other terpenoids may extend the therapeutic index, give you more leeway in the dose that can be used. Patients should never confuse psychoactivity with efficacy. What this means is that people should use an amount of cannabis to control their symptoms, not that which makes them high. So the lowest dose that produces a therapeutic benefit without associated adverse events is the correct dose. All of this is in a recently published article that, again, I'd be happy to send to anyone that needs it. Next, slide 36. What about use of cannabis in someone who may be dependent on opioids or reportedly to cannabis? Cannabis can be used concomitantly with opioids, even those who are medically dependent. However, obviously, close follow-up is needed. At a point where cannabis has been added, and the pain is reduced, it is possible to reduce or taper off the opioids. Now, interestingly, patients often do this on their own. Obviously, it's better to be done with medical monitoring of the situation. Also, if we have someone that has used excessive amounts of cannabis and might need it medically, there are ways to desensitize them to it. Basically, this involves stopping the cannabis for 48 hours and reinitiating at a much lower dose. There's a full explanation of this at the website of Dr. Dustin Sulak at healer.com. So even the patient who's already using excessive amounts might be able to succeed quite well on a lower dose with this approach. Coming to the end, the next slide, 37. What about recommending cannabis? This is a problem in some areas in the world. There was a court case in the USA about whether doctors could even discuss this with their patients. But in most areas of the world, doctors should freely discuss the pros and cons of cannabis treatment with patients. Certainly this should be documented in the clinical notes. There should be a complete history and physical done in any encounter. There should be plans for follow-up. And doctor can provide a letter or other documentation to attest to the fact that cannabis has been recommended for medical purposes. And with that, I'm not sure we've left enough time for questions, but I'd be happy to help if we do. Thank you. Next slide, if we haven't advanced already. I'm sorry I can't see.
Okay, thank you, Ethan. Thank you very much for your presentation. I'm not sure how we are able to make it with the questions. Somebody has a question? Někdo má otázky? I think, Ethan, we just give you a big thank you for your presentation, and because we are kind of like running out of time, I will tell the people just like maybe like give them your email and they can email you if they need to ask you something super important. Okay?
That's great. I answer my email, so I'd be happy to hear from you. Thank you very much, and have a nice evening.
Thank you very much for your presentation.
Bye.